All right. So thank you everybody for coming today. We'll be talking about Honor Pilot RCT and this the description of the full trial name there. So the objectives of today's talk would be to briefly talk about why do we need this trial. We'll speak a little bit about the trial details, about the interventions, which is going to be the helmet non-invasive ventilation versus control, which is the high flow nasal oxygen, and sort of go over briefly through the nursing, respiratory therapy, and research staff roles in this trial. And we'll provide you with an opportunity to ask questions after the presentation. So to kick it off, we'll start off by talking about why do we need this trial in the first place? Well, as most of you already know, acute respiratory failure is a leading cause of critical illness, and up to 40% of patients may require invasive mechanical ventilation. We all know that once you get intubated and are put on mechanical ventilation, you're at high risk of ventilator-associated pneumonia, ventilator-induced lung injury, and increased need for sedation. Non-invasive oxygenation strategies potentially are associated with reduction in risk of intubation, all-cause mortality, and they have a direct patient benefits with respect to comfort and work of breathing, and the patients obviously do not need to be sedated. They can continue to communicate with their bedside clinical staff and their loved ones. So in terms of the non-invasive oxygenation strategies that we have, there's really three. You're all familiar with the usual high flow nasal oxygen therapy there on the left side. In the middle, we have our usual face mask NIV, or otherwise known as BiPAP. What we'll be studying in this trial is this weird-looking helmet NIV interface. And the benefit here, of course, you can see that there is nothing sitting on the patient's face. It's a helmet that goes over the patient's head, and we're delivering high fraction of oxygen into that helmet with some positive pressure. So getting benefits both of high oxygen and positive pressure. This is a systematic review and meta-analysis that compared high flow nasal oxygen and helmet non-invasive ventilation to face mask, compared to standard oxygen, compared them to each other. And you can see that the use of helmet non-invasive ventilation is associated with lower rates of intubation when compared to standard oxygen therapy, as well as when compared to high flow nasal oxygen. There is also a signal for reduction in mortality when you use helmet non-invasive ventilation compared to standard oxygen and compared to high flow nasal oxygen. So there was a pilot randomized trial called HENIVOT. You can see the description. It was published in JAMA recently, and this was done in patients with hypoxic respiratory failure secondary to COVID-19. And it compared helmet non-invasive ventilation to high flow nasal cannula. The main outcome was to look at ventilator-free days or days free from respiratory support. But one of the secondary outcomes was the rate of intubations. And you can see that there was a significant difference between the two arms there, with the helmet non-invasive ventilation having a lower cumulative incidence of intubation compared to the high flow nasal oxygen. However, despite all of this preliminary data, there's still some limitation of knowledge to date, including low overall certainty of effect estimates. There are a few studies done with helmet NIV in general, and the studies that have been done are limited in sample size and are usually done at one or two experienced centers. The outcomes have been variably defined, and there was also a variety of severity of diseases when these patients were enrolled. And it's not very clear whether the effects seen in COVID-19 population extend to non-COVID-19 hypoxic respiratory failure patients. So this brings us to the details of the Honor RCT trial. And this is a pragmatic, multi-center, open-label, randomized control trial that aims to test the feasibility of conducting a larger definitive multi-center RCT. The trial will compare helmet NIV versus high-flow nasal oxygen in patients with acute hypoxic respiratory failure. And the large definitive trial will evaluate outcomes of intubation and the primary outcome of mortality. For this pilot phase, we're targeting a sample size of 200 patients. The study has been reviewed and approved by the Canadian Critical Care Trials Group. It has been funded by CHR and Sunnybrook Alternative Funding Plan. And the study PIs are Dr. Scales and Ferguson from Toronto. And our local investigators are myself, John Musmaji, and Ahmed Hegazi. So the research question that we're targeting is that, stated in a PICO format, is in adult patients who are admitted to ICU with acute hypoxic respiratory failure with the onset of less or equal to 7 days, does application of a helmet non-invasive ventilation in addition to high-flow nasal oxygen result in better outcomes compared to high-flow nasal oxygen alone? And so for this pilot feasibility study, we're looking at primarily feasibility outcomes listed there. Some of them include things like recruitment rates, whether the patients are adhering to prescribed therapy, rates of crossover from intervention to the control arm, adherence to the intubation criteria, which I'll share later on in the presentation, and also the time to randomization and how long does it take for us once the patient is randomized to actually allocate them, to initiate the treatment that they've been allocated to. In the main trial, as I mentioned, the primary outcome will eventually be all-cause mortality up to day 60 and intubation rate up to day 428. So here's a more detailed list of primary feasibility outcomes. You can see we'll be looking at recruitment rates at each individual study site. And we're targeting to enroll at least one patient per site per month to demonstrate the feasibility of a larger RCT. Hopefully we can beat this target and actually outperform some of the Toronto hospitals who already started enrolling patients into this trial. I have good faith because we've done this with the Save ICU trial, I'm sure we can do this with the Honor RCT here. We'll also be looking at rate of adherence to assigned oxygenation strategy, as well as crossover rates, as I mentioned, and all those other things that are listed there. There is a long list of secondary outcomes. Some of them are things like ventilator-free days, ICU length of stay, all-cause mortality, and we also will be looking at things like health-related quality of life at 180-day follow-up with these patients. And some of these outcomes will be collected centrally via telephone from the patients that are enrolled into the study. We will be monitoring adverse events in both intervention and control groups. And specifically in the intervention group, we're looking for things like skin breakdown or pressure sores, epistaxis requiring treatment, spontaneous pneumothoraces that are not related to other procedures like placement of central lines, development of subcutaneous emphysema, obviously occurrence of cardiac arrest, which is going to be a severe adverse event, upper extremity DVT, and again, the instances of barotrauma, which is basically a pneumothorax that leads to placement of chest tubes. In terms of the study process, this is how it's going to work. Our research staff will be screening patients in the intensive care unit with acute hypoxic respiratory failure. If the patient meets all inclusion criteria and has no exclusion criteria, they will be consented to participate in the study. If the patient is awake and capable, we'll obtain first-person consent. This can either be done as a written informed consent, or the patient can provide verbal consent that is witnessed by another staff, and we can proceed with enrolling them into the study. If the patient is not capable, we'll attempt to contact their substitute decision maker and obtain, again, informed written consent. However, if the SDM is not immediately available, the patient can be enrolled into the study and randomized using deferred consent, and then the research staff will follow up with the substitute decision makers and eventually patients to obtain consent, because consent is an ongoing process throughout the study. The randomization will be done in REDCap, which is a central database. It's available 24 hours a day, and randomization will occur in a 1-to-1 ratio. The key here is that once patients are randomized, they should be receiving initiation of therapy within 2 hours of randomization. So let's say a patient comes into one of our units at 10 in the morning. It looks like they need high oxygen support. They may already come in on high flow nasal cannula, and they meet all inclusion criteria. They have no exclusion criteria. You notify the research staff, who will attempt to get consent using one of the 3 methods listed there. The patient consents to the study, and then they are randomized. Once they're randomized, we'd like to see, and let's say they're randomized to intervention, which is the application of helmet NIV, that helmet NIV therapy should start within 2 hours of randomization. So there is a little bit of a time crunch here. Comparing intervention to control. Initial settings when you are using helmet NIV is you start off with a PEEP of 10, and we'll be using our ventilators to run these helmets. And you start with a pressure support setting of 8 to 10 centimeters of water, and then you titrate it according to individual patient. The targeting peak inspirator flows of greater than 100 liters a minute. You have additional settings that RTs, I'm sure, will be interested in, and we'll have all this information available for the RTs in a nice sort of study package lookup sheet. When the patient is randomized to the helmet NIV, they should be receiving this therapy for at least 12 hours a day for a minimum of 2 calendar days. If they need a break from NIV, they can go on high flow nasal oxygen in between these sessions, with the same setting of FiO2 and a flow rate of 50 liters per minute. You can start to wean helmet after 2 days, and or if PEEP is approximates centimeters water and FiO2 is 40%. Next we'll discuss the application of these helmets. And one thing I want to point out here, you can see myself trying these out in the RT room here. And the big difference between the helmet I'm wearing here and the one that we will be using in the trial, you can see that the one in the trial on the right-hand side here is actually detachable. It has a neck portion and a helmet portion. And the helmet portion actually screws in and screws out. So it's a quick release method. If you need access to the patient, if you need to give him a break, the whole thing doesn't need to come off. It's just the top thing can pop off and can pop back on. The ones that we were trying out during our in-services did not have that capability. So we got a more advanced version of the helmets for the study. I'll next show a video of a helmet interface that was put together by the Honor investigators. And again, what will be demonstrated is the old version of the helmet, that the whole thing has to come on, be put on, and then taken off as one piece. We're not going to be using this version. We're going to be using the version that has a quick detach here. But I'll play the video now, and it's about 4 minutes. So let's all watch it, and let me know if you can hear the sound.
This video features a guide on how to use a helmet interface to deliver non-invasive ventilation. Role described how to set the helmet, remove it, and initial ventilatory settings. Participants in this video purposely do not wear personal protective equipment in an attempt to preserve it for patient care. Likewise, certain devices such as high-flow nasal oxygen are not demonstrated in this video with the same rationale. Importantly, this video does not replace the manufacturer instructions and always refer to these for additional details. The helmet used for this video is the Castor R hood by StarMed Intersurgical. Inside the box, you will find the hood, the under armpits, and the original instructions. Some configurations will also include earplugs. Once removed from the box, the helmet should be reshaped and the patient's access port should be opened. This is a port to inflate the cushion that will provide a better seal around the neck. First, measure patient's neck circumference to select the appropriate helmet size. Next, place the underarm strips before placing the helmet. Use an ICU ventilator in non-invasive pressure support mode. Set the initial PEEP at 10 centimeters of water. Set the pressure support between 8 to 12 centimeters of water. Set flow trigger at 2 liters a minute. For the cycling off, start at 25%, but consider personalizing the adjustment. For the inspiratory rise time, use the fastest. An example, 0.1 seconds. For the placement of the helmet, 2 operators are needed. Using the fingertips, open the collar firmly and pass the helmet through the patient's head. Note that the access port is open while placing the helmet. Once the helmet is placed, you can provide oxygen through the patient's access port using a non-rebreather or high-flow nasal oxygen. Then connect the inspiratory and expiratory tubing and secure the under armpits to the helmet. This is how the setup should look like before the first ventilation. Please note a few things. First, the inspiratory tubing is disconnected at the ventilator connection, just for now. Note the presence of a filter at the inspiratory port in the ventilator. Also, there is no need for humidification, and therefore the setup bypasses the humidifier. The second filter at the inspiratory side is optional and could help decreasing the noise for the patient. However, the inspiratory filter at the ventilator side may be enough. Finally, note how it's possible to provide oxygen therapy through the patient's access port until ventilation is started. The additional filter in the expiratory side is not needed and was only used in this video to preserve the ventilator circuit. To initiate the first ventilation, one operator fits the patient access port and pulls from the anti-asphyxiation valve, while the other gently presses at the top of the hood and connects the inspiratory port to the ventilator. Pull the anti-asphyxiation valve until the hood inflates. Now the patient is ventilating. In order to inflate the cushion, you can use the oxygen attached to the wall. The cushion should be inflated but not under pressure. This is how the setup should look like. Remember, always support the patient with oxygen as soon as possible. Thank you for your attention, and please contact us with any questions.
All right. Well, thank you. So hopefully you folks got a chance to sort of see how this helmet is applied and how it's removed. And again, as I mentioned previously, the mask that we'll be using is the one here on the right-hand side that has a rapidly detachable hood. So hopefully that placement and removal will be less strenuous, especially for when we want to give our patients breaks from this therapy. So in the control arm, we'll be using our standard high flow nasal oxygen, and we'll be starting the therapy at 50 liters a minute and FI to 100%. And then you could titrate FI to flow for a SAT target of 92 to 97% as needed. And again, this therapy should be applied for at least 2 calendar days, at which point it can be titrated down. So the one thing is we'll be sharing intubation criteria with all our docs, and here are the list of these criteria. It's the same criteria that was used in the trial mentioned previously, and it sort of makes sense and reflects, I think, our general approach to intubation in this patient population. So the first one is obviously there's hemodynamic instability or impending cardiopulmonary arrest that requires urgent intubation. There's deterioration of neurologic status with inability to protect airway. There are signs of persistent worsening respiratory failure as defined by at least 2 of the following criteria. The patient's tachypnic. There is lack of improvement in signs of high respiratory muscle workload, development of copious tracheal secretion. There is acidosis based on the blood gas. The SATs are less than 90%, or there's a need for surgical intervention or procedure. The patient needs to go to the OR for whatever reason. So all intubations that occur during the first week will be assessed by site investigators for to determine which criteria have been used to intubate this patient. So if we can at least document them, the reason for intubation, it will be very helpful for us moving forward. So in terms of the study roles, nurses, RTs, and research staff. So for the nursing role, we hope that this is not going to impact nursing role too much. You'll be providing usual nursing care for patients receiving high flow nasal oxygen or NIV. The only difference here is in the actual interface. Some of the things that come to mind that may be a little bit different. You can see that if you need to suction your patient, there is a side port that can come off and you apply suction. But again, it will initially require quite a bit of collaboration between our nurses and RTs. So there will be slight adjustments, but overall the approach is very similar to what we're currently doing. For the RTs, they'll be working on applying the intervention, so that either with the helmet NIV or control high flow nasal oxygen, just the same way they do right now. And of course, titrating NIV and oxygen therapy. And just remember that a couple of caveats. Once the patient is randomized, if we can apply this therapy within 2-hour window, that'll be great. And also, if we can keep the patient in the assigned arm of the intervention for at least 2 calendar days, and for if they're in the helmet NIV, for a total of at least 12 hours per day for the first 2 calendar days. The research staff will be responsible for screening patients, randomizing them, and following outcomes, obviously the feasibility outcomes that I've listed earlier, as well as safety and adverse events. And this is where the research staff will be discussing with, speaking to the nurses if there's any evidence of skin breakdown, pressure sores, any concerns that you have that you think may be related to the device should be brought to the attention of the research staff, because this will be important for us to document in preparation for a larger randomized control trial. The reassuring thing is that in the previous small pilot RCTs in the COVID population, there has been no difference between the 2 arms. And as we know, helmets have been used quite extensively during the pandemic in Italy and in United Kingdom, routinely outside of trials. So we don't anticipate a lot of big challenges here. So I'll stop there. That's all I wanted to say, and I'll take questions. Thank you. Maybe I'll stop sharing the screen so I can see you folks.